Hello and welcome to Raider HQ After Dark. I'm your host, Raider. And in this video today, what I wanted to talk to you guys about is the shoulder. Now, the shoulder is one of those disabilities that, a lot of people typically don't have. It's not a glamorous disability by any means. But the reason why I wanted to do the shoulder today is because historically, the minimum rating for a shoulder used to be 10%. That is no longer the case. So, the minimum rating for a shoulder with painful motion at minimum, like if you have painful motion of the shoulder, which anybody with shoulder issues typically do, the minimum evaluation is 20%. So, if you happen to be a veteran who, historically got it granted and you've got a 10% for your shoulder, typically DC code 5201 for limitation of motion of the shoulder. That is an area that you could potentially go for an increase for and see your 10% turn into a 20% with little to no effort. I mean, obviously, if you have pain in your shoulder, that is something that's all you have to represent. It doesn't have to be anything fancy. We don't need a private DBQ for this. You do not need an attorney for this. This is just something that's going to be an increase exam. So, like with most of my how is it rated type videos, I'm just going to go through and we're going to talk about some things. So, I'm going to start off by sharing my screen and go into the 38 CFR for how it's rated. So let me just make things a little bit bigger here so that way you guys can see it. Now, this is what we're talking about. 5201 is arm limitation of motion. This is your shoulder. Okay, 5201 is what your shoulder is rated under primarily. Now, painful motion, minimum rating 20%. Now, the thing you have to consider for shoulders, any upper extremity type service connected issue is whether or not it's major or minor. And what they mean by that is they mean which handed are you? If you're right handed, is it your right shoulder? If so, at 20%, it doesn't necessarily affect anything. But once again, all you need is painful motion for the 20%. So limitation of motion limited to 90 degrees. So what this means is if you did not have painful motion, you could get the 20% evaluation if you were limited to making a T, like putting your arms straight out, and that's as far as they could go up in any direction, either to the side or forward. They could only go up to the shoulder level. If that's the case, then 20%, that's how 20% is evaluated. Now, if you can go higher than shoulder level, then you would be at 0%. Unless you had painful motion, at which point in time painful motion defaults as the minimum. Now, when we get to the next higher level, now I have seen a lot of people claim increases for shoulders, but it is genuinely hard to get a higher than 20% evaluation for the shoulder unless your treatment or circumstances meet this fact pattern. And I should say that flexion means in front of you, and abduction means to the side of you. So away from the body to the side. But what they're saying is when they review this, you start out at your arms down by your side. Okay, that is where the measurement starts. And that's how the 90 degrees comes from. It comes from you raising your arms from down at your side to, up to the 90 degree for this case. Now, for the 30% for the main hand and 20% for the offhand, 45 degrees. So literally you can't, and I have to say this, so I'm going to put this up. We're going to do a banner. Very important. You need to understand the distinction between what the limitation of motion means. It does not mean that, I start having pain at 45 degrees, so that I should obviously get the 30%. That's not what that means. Okay. It means that you physically cannot raise your arm above 45 degrees. If your arms are by your side and you try to lift them up to make a T, you can't get higher than 45 degrees. That's it. Physically. Like that examiner can reef on your arm and cannot physically bring it above 45 degrees. That's what that means. There has been a wild misconception about like what the limitation of motion actually means for the examiner. It is not associated when you start to feel pain. I need that to be said. So when we're talking about this right here, and when I mean like you physically can't go any further, imagine grabbing a 70-year-old man and trying to make him do the splits. At some point in time, the body will go no, right? Like you can't physically force him unless you're going to start breaking things to go any further down. That's what they mean. Like try to picture that in your mind of trying to force a 70-year-old man to do the splits and his body stopping at a certain point because it physically can't go any further. That's what they mean when on any of these shoulder, hip, knee, whatever. They mean if it's the limitation of motion is limited to that degree. Now, like with any other joint, that can be during flare ups potentially. So, do you have flare ups that limit you to a 45-degree, you know, limitation? Like that's as far as I can go is up to here. You can potentially talk to the examiner and report flare ups, but I'm just going to be honest with you. It has to make sense medically, right? If you have a shoulder strain, right? Like just a little, like a very minor shoulder strain that acts up every once in a while. You have to convince them medically why, how your shoulder strain can basically make it to where your arm can't move. So there might be a little bit of science that you need to bring into your examination and into your claim in order to show, or evidence from your doctor. Talk to your doctor about it and, just preface it like, hey, look, whenever I do this, I can't, and keep in mind, it's forward and to the side. So if you're like, yeah, I can't reach back and scratch my back, that's not what they're talking about, right? It's these planes of motion only. So not impossible to get, but harder to get. Easier to get if you have flare ups. Or, like, let's say you have a frozen shoulder or something like that. I mean, obviously, literally, you have some kind of arthritis that freezes your shoulder up. Fair enough. Now, the 40% and 30%. This is going to be the only time that the offhand for this actually raises above the minimum. So this is flexion or abduction away from the body, limited to 25 degrees from the side. Once again, same rules as this, where if you have flare-ups and that's the case, but you have to be able to medically explain it. You just can't go like, "Oh, I scratched my finger, so my arm fell off." Like it's got to make medical sense. Now then, so that's basically how the shoulder itself is rated. But I do want to bring up something else from the M21 manual. And that is that the shoulder, like other joints, can have separate rating decisions on it. So 5201 is the general shoulder disability. 5202 and 5203 have to do with the humerus, which is your the bone that connects, it's the upper part of your arm that connects to your shoulder. And then you've got the scapula, which is your shoulder blade. Let me just make sure that I got those right. So yes, 5202 is the humerus, and 5203 is the clavicle or scapula. So your collarbone or your shoulder blade. So that's the non-medical terminology for them. Now, you can get these also granted separately. So let's go back here to the M21. Now, it does provide a caveat here that the rater is going to be eyeballing pretty hard. if the manifestations represent separate and distinct symptomology. So if the examiner kind of says, well, yeah, but they're kind of, like the veteran has pain, but it's pain that can be generalized across the, at the shoulder level, but also down the scapula and down the clavicle. The rater should send that back and have them clarify that, medically, are they separate and distinct from each other, or is this one thing? Because we can't have pyramiding. We can't have that they're not duplicative nor overlapping. So if you have a shoulder condition, you might see that your claim gets maybe kicked back to the examiner via step whatever. I don't know the steps. Um, just to clarify stuff like that. And that would be normal. So sometimes you can see your shoulders get deferred back, especially if you've had like a situation in which you had an event in service, like an automobile accident, where you could have multiple, just based upon the nature of the trauma that you experienced, you could have multiple injuries, maybe like in this example, a humeral fracture resulting in restriction of movement of the shoulder and a clavicle fracture resulting in malunion of the clavicle. So, um, yeah. So if this was the case, if that was the fact pattern, then you could get, like let's say you just had a painful shoulder, 20%. Well, then you could also get, if you had malunion with moderate deformity, you could get a separate 20%. And then if, like, let's say your clavicle had dislocation of with non-loose, you could get 10%. Um, let's just do dislocation of the clavicle. You could get an additional 20%. So 20, 40, 60% just for your one arm. Very, very interesting, guys. So keep in mind that some of these, like older veterans, need to keep this in mind. So let me just say very important. So older veterans used to get, there were even different DC codes for the arm historically. It might be a good idea that if you're somebody who has had humerus and or clavicle injuries as a result of, like, let's say helicopter crash, plane crash, car crash, like any kind of event like that where it's a traumatic event, you could potentially have been, based upon the rules and regulations at the time that you got service connected, this might have been all we gave you, and we probably only gave you 10%. However, there is like I said, if you are 10% for the shoulder, you can potentially, like, and not just potentially, this is almost like if you have painful motion, that would be the only qualifying factor. You could get the new minimum 20% on increase, but you could also open yourself up to these other injuries. Now, what would you need for these other injuries? Obviously, a diagnosis. Obviously, also, these would need to be the result of an event in service. You couldn't say that, you had, um, like I pulled a muscle in my shoulder or something, like, or not that, but like let's say you like jammed it, like you fell on it. Okay, well maybe that's an injury too. Like a fall would be an event also. But if you have a sprain or a strain in it, it's hard to kind of, come up with how did you impair your humerus and your scapula or your clavicle if there's no evidence of it in service. So that's why I say that the events in service, like a car accident, those are a lot messier, where like just you were just banged around inside of the vehicle or the helicopter or whatever. Um, those are situations that make it easier to claim these also. Now, these things should be within the scope. So if you do an increase for your arm because you meet the new minimum requirement, like let's say you're 10%, then submit all the evidence for this stuff too, because these should be within the scope of the claim, especially if the shoulder injury is related to a trauma like a car accident. Now, what might happen is you might have to do them as secondary, or you might have to do them as direct. It just depends. And I'm mostly speaking towards older veterans, like pre 1980 veterans. because things were different back then. So we would, depending on how the rater, what evidence and what fact pattern your situation had, it might either be something that we raised to issue because that's something that we can do. It's within the scope and go, oh, well, this is just a progression of his prior injury. And we could grant that. But most, like some of the time, it will require a medical opinion. But just keep in mind that these can be separately granted now. So if you were holding back because you thought, oh no, I'm already being, service connected, I'm already being compensated for my shoulder. I don't need to go back for the humerus or the clavicle or scapula, the collarbone or the shoulder blade. That's not true anymore. You can be separately granted now. So, yeah, I just wanted to kind of put out a video. Now, for all of you that are claiming this is a new thing, um, there's some considerations here. So, obviously, I've talked about all three of these being separate, but just keep in mind that another thing to consider is, let's say that your dominant shoulder is service connected. A lot of the times, because we have to favor the shoulder. It's one of the joints that we use all the time, regardless. So if your shoulder, and this can count as a major or minor, but it's more effective on the major side of the fence. If your right hand dominant and your right shoulder is service connected, you might favor it and guard it and end up overusing your left hand, causing you to have a disability in your left shoulder. That is a very common thing that I've granted over the years is left shoulder secondary to right shoulder, service connected right shoulder due to overuse, or vice versa, depending on what, arm it is. But this is quite common. It's also quite common in most disabilities at the same level. So it works for the knees, it works for the ankles, it works for the hips. Even though you don't have a handed preference in it, you're still overused the what is considered to be the good joint when you guard the bad joint, at least if your evidence supports that. So it's just something I wanted to talk about, that if you're claiming the shoulder and you have issues with both shoulders, but like let's say that your right shoulder, you've got evidence in service, well, sure, you can claim that as direct. But if you also have evidence that your left shoulder is, kind of disabled due to your right shoulder, well, you can claim that secondary. And you can do it during the same claim that you're claiming the primary shoulder, but it does help to wait, in my opinion. It can help to wait, I should say. So we went over kind of some of the intricacies of the shoulder. Let's go to the DBQ. So this, guys, is the shoulder DBQ. And the shoulder DBQ, like so many others, has a lot of the same structure as other joint-based DBQs. So we come down here, we have, did the examiner review the records? If you are submitting a private DBQ for the shoulder, which sometimes people do, but not often, because the shoulder is kind of easier to prove. Nothing is ever easy to prove, but it is easier to prove. So this is where if you're doing like a private DBQ, you will want the examiner to say where and how, what information they have access to. Sorry, I had to cough there. And then we come down here to the dominant hand. Now, this is important, guys. There's no benefit to ambidextrous, really, uh, typically, but you want them to make sure that they get the dominant hand correct, just in case of the higher evaluations. Then we come down here to the diagnosis section. Now, with the shoulder, the diagnosis for the shoulder itself doesn't necessarily matter. It's not going to, I mean, as we saw here on the 5201, it's just range of motion for the shoulder itself. You don't have to have a specific set of symptoms other than limitation of motion. Any of these can cause limitation of motion. Arthritis can, ankylosis is a different thing, but sure. Rotator cuff tears, obviously. Now, if we come down here to the humeral head, and I'm going to try to find it. So we're also looking for the other conditions. So the impairment of the humerus and or clavicle. So what you'll probably see is this will be written down here in the other section for the clavicle and the humerus. Um, when we come down here to medical history, this is an important section, especially if you're dealing with a private DBQ, to talk about painful motion. What does that look like? What does like obviously the examiner is going to be asking you questions, but we also want to make sure that all the evidence, that you are reciting the same evidence that's going to be in your medical records. So, as a when raters review this, they they review to see if there's inconsistencies with the medical history versus what is presented. So just make sure that obviously if you're doing a private DBQ, proofread these. Make sure that everything's dressed right dressed, that it doesn't look differently than it should, right? That it's like, oh, everything's fine with my shoulder. If it says that in there, you need to talk to somebody, especially if that's not true. Does the veteran have flare ups? Now, if you remember back here, whenever I was talking about, the potential for getting the higher than the minimum for the shoulder, at least for this portion, then that's going to need to be, you're going to need to mark this yes. And if so, what's the frequency? What does it look like? Does the veteran report having functional loss? Functional loss is one of those things that some people think that if they mark yes here, then I can get the functional loss SMC and whatnot. This would be to start off a conversation about it. Then we would have to have medical evidence to support the factoid, right? Um, because we're not going to take the examiner's word on this. Even if they write nice things in here, it would need to know. Now, this DBQ is a little bit weird because it does, and I wish that they all did this, but they do right and left shoulder at the same time. So that way the examiner can do both shoulders at the same time. However, if you only claimed one shoulder, that examiner is only obligated to review that one shoulder. Sometimes they do both, like, you know, sometimes they don't. So if you only claim the right shoulder, that's it. And that is not a CUNE. If you didn't claim the like let's say the right shoulder. If you didn't claim the right shoulder and they didn't fill out the DBQ, then the process is working as intended. You cannot do a higher level review and just be like, they should have considered it. Then technically you should have claimed it because the duty to assist does not require them to do more for their money, like to do more evaluation than they are paid to do. So we have the normal range of motion stuff. If you guys have seen any of my joint videos so far, even if this is normal, that's fine because the rater will review and they'll input all of the ranges of motion provided. So, but the system will utilize the worst range of motion. And by worst, I mean the most limited range of motion. So that way you get the higher percent. So we come down here and is this an unclaimed joint? Is it damaged? If this is an unclaimed joint, is it damaged? So sometimes they will fill out this section here, but these are the joints. This obviously is the normal range of motion, which is 180, 180, 90, and 90. You want them to mark pain. So if you're looking at a private DBQ, or like let's say that you did a recent claim for the shoulder and you've got painful motion marked here, but they gave you a 0%, this would be grounds to fight it because this is enough evidence to support you getting the 20% minimum. So we do active range of motion. So this is your normal range of motion under no repetitive use or anything like that. And then we go passive range of motion, and then we go down here to crepitus doesn't matter. This portion, crepitus doesn't mean anything for rating purposes. This is the repetitive use section, repeated use over time section, and then we have flare-ups. So obviously, if you have flare-ups, you need to articulate that to the examiner, and they need to fill this section out. Please make sure when you proofread this, especially if you're like, I always suggest trying to get a copy of this after you get the rating to make sure that you were accurately assessed. But also, if you have a private DBQ, please make sure that the flare ups are worse than other ranges of motion, because a flare up is meant to be the worst instance, like the most limiting factor. It's like your worst day. That's what the flare ups are. Typically, I have seen it to where the flare ups were better than the repeated use over time. And I'm like, what? And I sent it back because I'm like, what you doing? Like, it didn't make any sense. And then they fixed it. They were like, oh no, I forgot. I superimposed the wrong numbers on there, which happens sometimes. Now, additional contributing factors, none of these really matter, because I mean, if we come back here, it's only range of motion, right? Like, that's all we care about is range of motion. So this section doesn't matter at all. Muscle atrophy, I mean, yeah, but not really for what we're talking about. Ankylosis, sure, that can be a thing. Rotator cuff conditions, fair enough. What I'm looking for here is shoulder instability. So shoulder instability, that's whenever we're going to look for the dislocations. Wait, where is it? Of the humerus. Loss of head, recurrent dislocations. Here we go. So this section right here is when you're dealing with 20 or 30% for these frequent episodes. This section of the DBQ, section 7, is about the dislocations. And then we come down here to the clavicle, scapula, acromion clavicular joint, and sternoclavicular joints. So section 8 is going to be when we're talking about this section right here. So, and this is just going to be plug and play. So the examiner is either going to check boxes for this stuff right down here in 8C. Is there some kind of impairment? Yes or no. If they say no here, then this door on this thing shuts because they said no. If they say yes here, then they get to check whichever box, and we will grant accordingly. There's not much pushback on this because there's not too many diagnostic tests that can be done. And I probably should have made this bigger, but that can be done to kind of overcome any kind of doubt. I mean, we just take the examiner's word for it. And then we come down here. This is the humerus section. So this is going to be where they check the boxes: loss of full head, non-union, fibrous union. And as we see up here, it's going to be pretty much the rater is going to transpose whatever the examiner puts on the DBQ into VBMSR, and that's going to be it. There isn't too much in the way of, like I said, if there's loss of head, we'll want to know, like, what's going on with that, because if some of these have to do with there should be some treatment for this, but overall the rater shouldn't bucket too much because it just comes down to this. Obviously, if there's any surgical procedures, we'll need to know those. Surgical procedures for the shoulder are important because they get convalescence. And shoulder convalescence, and we're going to go for clicky click 50-55. This will at least take me to the section. So I want shoulder 50-51. So if you were to have some kind of resurfacing done or a shoulder replacement gives you 1 full year of convalescence if you have a complete total shoulder. And then after that 1 year, then we rate residuals. The minimum rating for a shoulder replacement is going to be 30% for the dominant hand, 20% for the non-dominant hand, or you can have these two right here, which are basically if you have chronic weakness or painful motion after the surgery of the total shoulder, then you can get 60% for the dominant hand and 50% for the non-dominant hand. Now, you can also get, if the symptoms, there's an intermittent degree of residual weakness, pain, or limitation, then we can rate you under the normal rating code of 5201, 5202, and 5203, depending on your symptoms. But what'll happen is you'll get the higher of the two. So if the minimum rating is higher than what you would get as if you were to separately rate these out, then we'll give you the minimum rating. Or we can go 5200. Let me see that. So 5200 has to do with the special circumstances of ankylosis after the surgery. So it has its own rating scheduler. But we're at the 30-minute mark, people. So that's about all I got for you today. Obviously, if I'm going to scroll down just a little bit right here, assistive devices don't matter here, but diagnostic imaging does help, to prove certain things for like degenerative arthritis or, like if you have flailed head or something like that of the humeral head. Functional impact, this does not mean what you think it means. This is, if they marked yes here, it does not mean that you have a CUNE because they didn't do IU review. That's not what that means. That's the rater's not compelled to use this to invoke IU. So supplemental claims or higher level reviews based on that won't get you too far. They'll just send you would you like to they'll solicit you a claim for IU at that point in time, but it's not a thing where you can get an earlier effective date because functional impact wasn't considered in the rating decision. But this is another section where the remarks you want to review at, because especially if you have a private DBQ, you do not want to, I should say, you want to make sure that all of your information's dress, that it all matches up and it's all flowing in the right direction and that there's no conflictions in here, because sometimes the examiners can get things screwed up in their heads and write down or transpose something that makes no sense and it goes against everything. And it just makes the rater have to defer it back and clarify. Now, also, private DBQs, make sure all of this stuff is filled out and that all of it matches up. If they're on their national provider index, whenever you look, I would suggest you go look up their NPI number and their medical license. And I suggest that you make sure that all of their address, their phone number, all of that stuff lines up for a private DBQ, because if it doesn't, that's grounds to find it insufficient, because their information, their national provider number, maybe their address is in Georgia, but they've recently moved. They need to have all their stuff up to date for us to consider it. But that's about all I got for you guys today. Let me take a moment here and just thank everybody for watching, subscribing. We're doing awesome. The channel's growing exponentially. I appreciate all your dedication, the comments. I'm trying to get to the emails. I'll be honest with you, I don't have much free time for the emails, so I'm just trying to knock them out as I can. But I am trying to keep up on the comments. Let me know if you guys want any additional videos or anything like that. Like what kind of videos do you want next? But other than that, thank you. Thank you to all the members, VSRs and Rares. Forgot to mention you guys, but you guys keep the channel going. So thank you. Raider out.